Ventilation is an extraordinary form of therapy, but we do it well when we know its physics and maths too. We've heard some talks about tidal volume, minute ventilation, oxygenation, and the factors that determine each of these. And essentially, the goals of ventilation are these two alone: to optimize oxygenation and to improve gas exchange, as in carbon dioxide. But today we are going to look at certain maths and physics principles which have a bearing on all of these things that you've already learned and will be learning through the ventilation workshop. So let's start with something that we all are familiar with: a structure, that is a rubber band. If you were to stretch it or apply a certain force or pressure on it, then it would move from its original structure or shape to some other shape. Similarly, if you look at a three-dimensional structure like the balloon, then if you were to apply a particular force or pressure on its mouth with your mouth, then you would inflate it from a state of collapsed configuration into a more expanded form. So there'd be a difference in the amount of pressure that you have to apply to just open up a fully flaccid balloon, or to open up a balloon that is partially filled to a larger sized balloon. We can add one more scenario to it. By attaching a straw to the mouth of the balloon, you'd be creating or simulating something like an airway to conduct the force that you are applying in order to expand the balloon. So with that, let's move to the first concept, which is the compliance. Compliance is essentially of three types: static, dynamic, and specific. So as the word suggests itself, static compliance is measurement of volume for a given pressure at a state of no flow when you're measuring. That means there is no active flow happening when you're measuring static compliance. So you allow a particular substance, say a balloon or the lung, to inflate to a particular volume, allow some time for equilibration to happen, to allow all the other forces like pendulift or like resistance components to be negated, and then you measure the volume and the pressure at which the balloon or the lung is sitting. Then you get a graph which denotes static compliance. So if you were to have the x and the y-axis, in mathematics and physics, the x-axis is always the independent variable. That would be pressure in this case. And it is pressure changes that is going to determine volume changes. And therefore, the y-axis would be representing volume. So if you were looking at static compliance, it would be a curve. The curve would have slopes at various areas. There would be one slope at this point, there would be another slope at this point, and there would be another slope at this point. Slope in mathematics again is change in the y-axis for a given change in the x-axis. So suppose you were to take a change in pressure from P1 to a point in pressure P2, then the corresponding change in volume that you have achieved, that is this delta V for this delta P, would give you static compliance. So the slope of this graph is what is compliance. Now, since there is really no situation where you have no flow happening, either in a spontaneously breathing baby or even in a ventilated baby, static compliance concept is to be used mostly in research or in just understanding the concept per se. It doesn't have any real practical relevance. So we'll move on to the next type, which is called as the dynamic compliance. So like the name itself suggests, dynamic compliance means that you have it measured on the fly. That is when the flow is actually happening or when breathing is actually happening. So when the baby is spontaneously breathing or invasively ventilated, it is measured or calculated by the ventilator between the peak and the peep. So these are apparent zero flow points, that is the peak and the peep, and the machine creates a graph. So again, the graph has pressure on the x-axis and volume on the y-axis, because these are the independent and the dependent variables respectively. And then if you look at what is happening with flow during inspiration and then during expiration, you would create something called a hysteresis. So since the baby is actively breathing or you have mechanically ventilated him with a flow that is ongoing, you will not get a graph that is simply a curve, but you will get a loop, which is called as the hysteresis. Now, this concept is important to understand. Why is there a hysteresis when you're measuring dynamic compliance as compared to a simple, straightforward curve when you're measuring static compliance? This has got multiple reasons, But the most important which will be three. One is that you have surfactant in the lung. So if you have surfactant in the lung during expiration, it prevents the lung alveoli from collapsing from a inflated state to a deflated state. So for a particular pressure point, that is say P1, if you were to measure the volume of the lung in inspiration versus the volume of the lung in expiration, you will always get the volume in expiration to be higher than the volume in inspiration. That's because there is a brake applied during expiration by the surfactant in preventing the lung from collapsing. That is one of the important reasons why a hysteresis loop is created. The second reason is the physics property of any substance that can be stretched, whether it be a rubber band, a balloon, a lung, or a metal, or whatsoever in the universe. The path that the material follows during stretching is not the path that it follows while it comes back to its original state. So that's one more reason why you have a loop created instead of a simple graph like you can see here. If it is static compliance and if it was the same during inspiration and expiration, you have to have it going on and on in the same line or the same slope itself. But that's not what happens. You create a loop where you have an inspiratory pathway and you have an expiratory pathway. So we saw two important concepts that create hysteresis. One is surfactant, and second is the physics property of the material itself. And the third important component is resistance. So since we have flow happening, anywhere where there is an active flow happening, resistance comes into play. This concept we'll look at in a little while later when we're talking about resistance. So if you were to draw the slope of this graph, that slope, that's delta V by delta P at various time points, will be what is going to give you the dynamic compliance. Now, since dynamic compliance has flow happening and static compliance has no flow happening during measurement, flow contributes to resistance. Therefore, at any given point, the dynamic compliance of the lung would be lesser than the static compliance of the lung. That's because there's no flow happening in static state, and therefore resistance doesn't come into picture when you're measuring static compliance. So if you were to look at change in compliance, the cliche graphs that we always get for exams as well as for clinical practice, if you were to look at two situations, again, you have P here, V here, P here, and V here. If suppose you have a lung that has no surfactant and has not been recruited, you have multiple collapsed alveoli, then you would probably have a hysteresis loop that is lying down on the x-axis. That's because for any given change in pressure from P1 to P2, you'll get a very tiny change in volume. That's the slope of the graph. So this is the delta V that you're getting in the first situation. Now, suppose you realize that this lung is not good, you have given surfactant to them, you have maybe recruited more alveoli and so on, and done certain maneuvers, then this particular graph is going to then look like this. So now if you look at the slope, you will find for the same delta P, so from point A to point B, you will find the volume change that you have created is much larger. So the slope of the second graph, that is this one, where you have delta V by delta P, the compliance is going to be much higher than the first situation where delta V by delta P is extremely small. So that's how you understand the compliance changes that can happen where various mannerisms or various maneuvers that you use during therapy of a ventilated baby. Now, there's one more situation that you need to know before we come to this slide. You need to know that in the same graph, you can have three different compliances. So again, you have pressure and you have volume here, and you can have a graph that looks like this. So you need not have different lung units, different lungs, or different situations before, after, etc. In the same baby itself, in the same breath itself, you can have a graph that looks like this. That is, if you have given something that is very low, that is, if your PEEP set is much lesser than the FRC, then it takes more pressure to achieve a volume up to a particular point, and then only your delta P is able to create some delta V, and then you've gone on to a state where you've hyperinflated the lungs, and therefore, again, the delta V that you can create for delta P is much lesser. So you can have three slopes in the same graph, where you have very low compliance in the state where you haven't inflated lung units adequately or recruited lung units adequately or not given surfactant and so on. Then you have allowed the lung to inflate to a particular PIP and you create a particular compliance in that part of the slope. And thereafter, because you've overinflated the lung, again, an overinflated lung is not able to achieve a delta V for a given change in delta P, and the slope again starts lying down. So if you have a lying down slope, it means that your compliance is very poor. If you have a slope that is trying to stand up, then it means that you have a compliance that's improving. So if you have a beaking over here, it means you have probably overinflated lung. If you have something that's looking like this also, you're probably wasting time, wasting pressure exposure, and unnecessarily creating trauma to the lung by not recruiting adequate alveoli or by not giving surfactant to this baby. So you can have different situations in the same graph itself. Now we'll go back to the slide, which is most important to us. That is the various factors that affect compliance. The most important of which we've already talked about, that is surfactant deficiency, because you don't allow the lung to expand, and once it's expanded, it starts collapsing with no surfactant within the alveoli. Now, if you have less lung units available, either because you haven't recruited them adequately, or you haven't applied FRC, or because the lung itself is insufficient, like you have a pulmonary insufficiency of prematurity, or a pulmonary hypoplasia that has happened in a term baby due to a Potter sequence or a severe oligoamnios antenatally, or you have an external compression on alveoli that could be recruited potentially. This could be because of a pneumothorax or a pleural effusion outside that is not allowing you to expand the lung. Then the amount of volume change that you create for a particular pressure change can also decrease. The other is if you have collapsed alveoli, not just because of a unrecruited ones, but because you have a bad tube position. A very deep tube can create a left lung collapse, a right upper zone collapse. You can also have a consolidation within the lungs with increased amount of fluid and inflammatory substances like in a pneumonia or a pulmonary hemorrhage or a meconium aspiration syndrome. All of these can also affect compliance. So anything which decreases the amount of volume change for the amount of pressure that you have applied can decrease compliance. So with that, it's important for us to understand one more concept before we move on to the next one, that is chest wall compliance. Now, the chest needs to have some reasonable amount of ability to prevent collapse of the lung, but also have some reasonable amount of allowance to allow the lung to expand during inspiration. So the chest wall actually applies brakes to expiration so that the lung doesn't completely collapse when the baby is breathing out. So if the chest wall is very compliant or extremely amenable to changes in volume, that is also not good. You might have collapsed lung because the lung cannot be, the expiration of the lung, you can't apply brakes because of the chest wall. And the second thing is that if the chest wall is very low compliance, as in a very scleromatous baby or a very severe edematous baby, or a thoracic dystrophy where you have the shape of the chest itself being abnormal, then the chest wall compliance can be decreased. So if that happens also, it can be very difficult to inflate the lung. So both situations are not good. If you have a highly compliant chest wall, you might be having a lung that is going to collapse with each expiration, as happens in very small babies. If you have a very low compliant chest wall also, like in a thick chest wall, like edematous chest wall, then you might have difficulty in ventilating these babies as well. So with that, let's move on to the next component, which is resistance. So if I were to say that I am a very resistant person, what would it mean essentially? It would just mean that I don't want something to flow into my brain. And if I have already developed certain concepts inside my brain, I wouldn't allow that to change either, or I don't allow flows to happen from my brain outwards. So anything to move from one point to the other, that is from point A to point B, you have to have certain difference between them. So you have to have a concentration difference or a potential difference, like in electricity, or you have to have a pressure difference. So if you have P1 larger than P2, then there will be a flow achieved from P1 to P2. So you have to have some kind of difference in pressure in order for a flow to move. So the amount of pressure that is required for a particular flow to happen would be resistance. So the unit of this would be millibar or centimeters of water divided by a unit of flow, which could be liters per minute or ml per second, etc. So resistance has a flow component to it. So R is equal to the pressure that is required to create a particular flow. P by flow would be R. So actually, resistance has three things or three components to it. It is tissue resistance, inertance, and airway resistance. But since this is the most relevant to us when you're mechanically ventilating a baby, we'll talk more about airway resistance. So in order to understand airway resistance, you're going to have to learn 3 physics concepts or revise 3 physics concepts. The first one being that resistance is proportionate to 8 eta L divided by pi r raised to the power of 4. So all of us are quite familiar with this, but we will understand only 2 simple things, that the resistance is directly proportionate to L, or the length of the tube through which the fluid is moving, and inversely proportionate to the 4th part of the radius of the tube through which the fluid is moving. So this radius can be affected by various things. It could be an external compression like a mass or a pneumothorax, or it could be even an intrinsic inability of the airway to remain open like in tracheobronchomalacia. It can be internal compressions like secretions or even blood stains or clots sitting inside the tube, or simply just a tube that is too small for the baby. So the radius of the tube through which the particular flow is happening has a very important bearing on resistance. That's the first concept. Now, the second concept is to do with the fluid that is passing through it, or the flow rates that are passing through it. That's the Reynolds number. So if you were to fill a vessel through a particular tube, then if you allow smooth flow at correct flow rates, then the vessel would fill correctly. So that is called as laminar flow. Now, if you were to increase the rate of that flow or to create a turbulence in it, then you will be creating whirls and swirls inside. And finally, the amount of filling that is going to happen at the distal end is going to be much slower or going to be not effective. So you do not want a turbulence to happen. So the property of the fluid that is passing through it is the second important concept that you need to understand when we see what determines resistance. And the third concept is the Poisely principle. So if you have a fast train moving in, suppose the Vande Bharat train is coming in, or a Japanese high-speed train is coming in, then you would be not advised to stand somewhere close to the train track. That's because if you have a very high velocity movement happening, then the pressure across that change, or the pressure across that substance which is moving, is going to drop. That is a Poisely principle. So if the train were to come in at super speed and you were standing very close to the train, then the pressure drop created by the increased velocity of the train is going to suck you in to the tracks and be fatal to you. So fast and rapid flows through an airway, very fast flows through the airway, can create a pressure drop across this point and cause the airway to collapse inwards. So if you have a very high flow happening, then you would have a drop in pressure across that point. Now let's remember one thing here, that the process of inspiration is an active process. So whether it be a breathing that is happening spontaneously or a assisted ventilation that you're doing, inspiration, you're actually pushing in flows to happen and somehow the airway would remain open. But expiration is a passive process and it depends upon the movement of gas flows from inside to outside by a passive process. So if you were to collapse these airways, it would affect expiration more than inspiration. The airway would somehow remain open during inspiration, but during expiration, the various factors that you just saw would affect the resistance. It would lower the tube's diameter. It could even compress the airway from outside. It could create a vacuum and the airway to collapse from inside. And it is the expiratory resistance that is going to go up most importantly. So if you were to allow a lung to deflate, you have to allow enough time to overcome that resistance in order for the lung to deflate correctly. So with that, we'll move on to what is the third one, which is time constant. So time constant is another factor that is borrowed from mathematics. It is the time taken for a lung unit to inflate to a desired volume or to deflate from a desired volume. People also talk about it as the amount of time taken for pressure to equilibrate from one point to the other too. But essentially, it's a volume concept again, that it is the amount of time taken for a particular substance or a particular lung unit to inflate to a desired volume or to deflate from a desired volume. So you're talking about two time constants. It's TCI and TCE. Okay, so that's about the definition of time constant. So if you were to look at a graph again, if this is volume and this is time, and this is the maximum volume that is achievable. Let's talk about expiration for some fun. So if this is 100% of the volume, and if you're going to allow it to expire or move out of that particular place, that is the lung, then the graph would look somewhat like this. So it wouldn't be a linear graph, it would be a curve. So at one time constant, you would be able to take out 63% of the volume, left with only 37% here. So the amount of time taken to take out 63% of the total volume that is already there is one time constant. If you were to allow 3 time constants here, then you'll be able to take out at least 95% of the total volume. So if you want to really empty the lung to 95% of whatever volume it was originally, then you want to set 3 time constants for that particular lung. So what determines time constant is what we talked about previously. The formula for time constant is compliance into resistance. It's easy to remember. Let's do it. Now, time constant is represented in seconds or milliseconds. That is a unit of time per se. And compliance is a delta V divided by delta P. Resistance is pressure difference by flow. So if you were to cut off all the units, you'll find that what you're left behind is unit of time. So time constant is compliance into resistance. So if you were to, like we saw in the previous graph, allow the lung to inflate or deflate, you have to have enough time to happen, for it to happen. So if you were to set 3 times the time constant that is determined by the physiology of the lung that you are ventilating or the pathophysiology of the disease that you're ventilating, then you will allow at least 95% of the desired volume change to happen, whether it be in inspiration or in expiration. So there are various situations that you can take into picture. You can have a lung that is not compliant, that is very low compliance. These lungs would fill faster, which means the time constant would be less, but the volume that you achieve finally would be much lesser. The TC would be less because it would fill faster. This is what you would see in an RDS lung. If you were to look at a BPD lung where the compliance is essentially taken as normal, but the resistance of the airways during expiration is very long or very high, then it would take much longer to empty, but it would finally empty. So the expiratory time that you would allow may have to be much longer if you have a BPD lung that has a bad airway. So today we've seen 3 physiologic pillars, all of which have a bearing on each other, that is compliance, resistance, and time constant, and also on impact the way you mechanically ventilate or look at a baby when you're doing it with reference to the pathophysiology of the disease itself. Thank you.